Okay, folks, welcome back to our session 3 of our first virtual Microbial Sciences Initiative Symposium. This is a session we added quite recently because thankfully Dr. Erica Shenoy, who I'll introduce momentarily, carved out the time to speak with us today. Dr. Erica Shenoy is from Mass General Hospital, and she's an infectious diseases physician and an assistant professor of medicine at Harvard Medical School. She's also the medical director of the MGH Biocontainment Unit, one of 10 facilities supported by the U.S. Department of Health and Human Services as part of the regional treatment network for Ebola and other special pathogens. She has served as the infectious diseases and infection control advisor to MGH and Partners Healthcare for the COVID-19 response. Dr. Shenoy is co-chair, along with David Weber, of the Sterilization and High-Level Disinfection Guidelines Committee of the Society for Healthcare Epidemiology of America. We are very pleased and very grateful that she's been able to take time out of her very busy schedule to talk to us today about our community's responses, and MGH's in particular, to the current pandemic. Dr. Shenoy, thank you again, and the screen is yours.
Hi, can you hear me? Hi, can you hear me? Peter? Hello?
Oops.
Yes, good to go. We can hear you.
Okay, let me just pull in my
Let's see here.
presentation.
I think you need to unmute.
I am. I'm unmuted. Give me a second.
Okay, there you are. I'm sorry. And I will go ahead and mute myself.
Okay, and let me just make sure you can see my screen.
Looking good?
Okay, can you see it?
Yep.
Okay, great. Well, let me just move this so I can see. So this is a very different talk than what I've been hearing today, where it really took me back to some of my days in molecular biology, but that's been a long time since then. And I'm really going to give a talk to explain to you and show you what's been going on at Mass General, one specific hospital, as we've been addressing the COVID outbreak. And I'm doing it in a timeline format and going to try to relive how we have evolved over this time over just 3 months. And I'm going to show lots of pictures so you can see what it's like being here in the hospital during this time. So I'll go through just a very brief background and kind of set the stage where we were in January as things started to unfold. I'll tell you about the activation of what's called the Hospital Incident Command Structure, and in emergency situations, this is the framework that we use to be able to respond quickly and decisively as an emergency is unfolding. I'm going to give you some insight into our current states and trends at the hospital, and I'll have data as recent as just a couple days ago, and really spend most of the time talking about how much has transformed in such a short period of time for an institution that's well over 200 years old. I think that we've probably changed more in 3 months than perhaps over a much longer period of time. And I'll give you some of the insights into that from the clinical care perspective, from some of the amazing innovation that's been happening, and just and on some of the research that has been evolving here and will continue to as we kind of get to the peak and then make our way down this curve. So I actually went back to some of my slides from late January when we first activated our incident command. And when I gave the presentation to the incident command, and as well as the infectious disease division, where I'm one of the physicians here, I kind of laid the groundwork for the coronaviruses, which at the time, what we were talking about were that there were generally known as pretty mild infections. So the four or five commonly circulating coronaviruses cause about a third of the common cold syndromes. And we don't actually test for these in a normal year. You know, we're testing for flu, we're testing for respiratory syncytial virus, but we're not really focused on these viruses. The reservoirs for coronaviruses are known to be bats and many other animals, including civets and dromedary camels. And until 2002, really not on the radar in terms of an important pathogen to worry about, because they had such mild illness and still continue to do so, at least for the ones that we commonly see each year. And then in 2002, there was the severe acute respiratory syndrome. And actually, when I wrote this slide, it was not called SARS-CoV-1. It wasn't until the current virus was named SARS-CoV-2 that we now had the second iteration of it. And in SARS in 2002 was about a 4-month outbreak. There were about 8,000 cases, 800 deaths, and about a 10% mortality rate. But in the grand scheme of things, that was started and ended within a short period of time. Now, Middle East Respiratory Syndrome, which is what we have been preparing for as one of the special pathogens treatment centers for many years, has actually been around since 2012, and each year there are about 200 cases. And a lot of our focus, in addition to focusing on the viral hemorrhagic fevers like Ebola, had been on preparing for the eventual, we thought, inevitable introduction of a patient with MERS to our facility, just given the travel from the 14 countries where MERS continues to circulate. And then just in January, there was this new virus. At first, it was 2019 nCoV, and we were wondering what name it would be given at the time. And this is just a description of the coronaviruses that we were presenting at this time, and they were similar in certain ways in terms of our thoughts around transmission, the fact at the time there was no treatment, directed treatment for any of these, and the kind of standard infection prevention approaches. And this is what the dashboard looked like that day, where really everything was focused in China, and not just in one particular area in China called Wuhan, China, which I'm sure everyone here has heard a lot about. And what we were really concerned about at the time was the travel implications, that this is just one diagram, and if you overlay all the other air travel, you can see how pathogens can start in one place in the world and end up all over the world. We knew very little about the clinical characteristics. There were just some small case series that were being put out in the literature, and as I'm sure you're aware of, the amount of literature that is emerging has been so fast-paced that we were essentially, trying to keep up with it day to day and determine if the latest paper or case series meant that we had to change our approach in any way at the hospital. So that's by way of background, and I'll start talking about the activation of our incident command structure. So on January 27th, MGH formally acted its incident command structure. We have a daily briefing. It's actually twice a day. We start in the first thing in the morning, and then by the end of the day, we meet up to make sure that we're all on the same page in terms of what has been done and what needs to get done. We've had to evolve this meeting. Initially, we're all together in one room, but obviously with social distancing and the goal to make sure that we're able to abide by that, it's mostly like many of our meetings right now are Zoom meetings with just a few people who are in the room together here in the building where I am in the trustees room. The incident command structure really should look pretty similar at any institution that you go to. We have an incident commander here at the top, and Prestipino. We have communications is very important during an event like this. We have a liaison officer who's working with external agencies, a senior advisor. I serve as the infectious disease and infection control subject matter expert, and then we have section chiefs. And this is a pretty redacted version because there's lots and lots of individuals that are under each of these sections of our command system. So starting on the timeline, actually before the 27th, we had already been evaluating patients that we were worried about COVID in. So on January 11th, we had one of our first patients who arrived. We evaluated that patient, and in discussions with public health authorities, decision was made not to test that patient, and they were sent home. A second patient came in a few days later. They didn't meet the testing criteria, which was pretty stringent at the time, and they were also sent home. About a week later, we had a third patient. They actually had the correct syndrome, the travel history, but because they didn't have pneumonia, they were sent home without being able to test them. At the time, testing was incredibly restrictive in terms of what we were able to test. But that person actually returned again a couple days later, and at that time required admission, and we went on to test that patient, who eventually was negative. But this sort of kind of rapid pace of having individuals come to our facility at this time who were starting to potentially meet criteria led to the activation of the incident command structure. At the time, the definition, it's called the person under investigation definition from the CDC, and actually there were 4 iterations of this over time, was really restrictive. And it meant that we, patients who arrived to us who we thought, could have had this disease, we were just unable to test them because we did not have access to the test and they did not meet the criteria. A few days later, the first confirmed case in Boston was on February 1st. And on the 6th of February, we had 2 additional patients that we were able to test, and they were negative. And for the next several weeks, we had an increasing volume of patients presenting for evaluation. The testing criteria was evolving over time. Some of these patients were admitted, others were discharged home, and it became really just incredibly intense with the volume of individuals presenting. Again, this is in the middle of flu season as well, and so individuals presenting with a very similar syndrome and not having really immediate access to testing to be able to discern if it was influenza or COVID was incredibly challenging. In March, March 4th, we had 5 patients presented around the same time. Actually, they all came pretty much together. 3 of those 5 individuals met testing criteria, and we sent the test and we sent them home. They were well enough to go home. And 2 days later, 3 of the patients, the 3 ones we tested, were positive. And this led to kind of the start of the ascent of the curve for us in terms of cases. And we needed to open immediately a location to be able to test patients. And this was really about the Biogen outbreak. And so many of you may be familiar that around, I think it was March 4th or March 5th, there was an announcement that 3 individuals who had been at a Biogen conference here in Boston had, after leaving, tested positive. And so we had an additional 3 patients from the following day who had come and tested positive as well. We were contacted by the Department of Public Health and made a decision in collaboration to set up a testing site to be able to, as quickly as possible, test a large number of individuals who had been at that conference to try to do contact tracing and isolation of this event. So with such a large number of individuals who needed to be tested, we ended up turning a large indoor garage where normally all the ambulances come to drop off patients into a testing site. I'm just showing you some pictures. It was set up in a way that would be efficient and appropriate for infection control reasons, with separation of patients, appropriate use of personal protective equipment, and trying to facilitate entry and exit to the facility as quickly and as safely as possible. These are just some images from the time. So that's where it all started, and I'll show you where we've come. So this is a map showing you the number of cases admitted to the hospital. And I'll get into a little bit about the kind of epidemiology here in terms of the proportion of patients that have required admission. But I was just telling you a little bit about early March, and there were just a little bit of cases. They were outpatient cases. In the yellow, you'll see our total case counts. I think today, this is from a couple days ago, today we're over 340 or so of confirmed cases in-house. They are split in the blue. There's our general care, so not intensive care beds. And on the orange lines, you'll see intensive care. And the intensive care burden is very profound, I would say, and I'll give you some stats that show you how different it is in terms of our intensive care utilization compared to normal state of affairs. So we've certainly seen a large increase in admitted cases. These are patients who actually require admission to the hospital. The vast majority have not required that, but we certainly have a large number of patients here. This is a figure showing of patients who have been admitted. Are they still admitted? The teal bars are people who've been discharged, and I think that's a good news story that we are able to have patients require hospitalization. Many of them are going to the ICU, but many are recovering, and that's a really a wonderful story, and there's many wonderful stories showing just incredible work that's being done to make this possible. Where are patients coming from? This is a catchment analysis where you can see that From the beginning, we've certainly had in the blue here, and this has been reported now in the Globe and many other locations, we've had some hotspots around in the Boston area where there are just a larger proportion of individuals who have infection. And these are patients who have been admitted to our facility from these different areas. Ventilator use, so here you'll see our ventilator use in the blue bars. We've got the patients who are confirmed COVID. In the orange, those who are undergoing a rule out who still require, who need ventilator support. And the gray bars are just the few patients remaining who are in our facility and do not have COVID. And just to remark, as a point of reference, our historical ventilator use at Mass General is 47 patients per day. And you can see here, we just have an extraordinary number of patients who require ventilation in the facility. This is a figure showing our patients who have never required admission. And so that's a great story. They're tested, they're positive, and they don't require admission. Those are the green bars here. In the red, these are patients who were tested as an outpatient and eventually they've required admission to our facility. But it does show you that, you know, it is a small proportion of all the patients who actually end up requiring admission to our facility. So I'll go through some of the transformative events that have happened over this time, a lot of this with pictures, again, just to give you some insight into what it's been like. So here's a timeline of how we've had to convert units in our hospital into COVID care units. We started with just this one unit. This was our unit as a Ebola and Special Pathogens Treatment Center that had been specifically designated with 18 beds, 10 beds originally, but the possibility of 18 beds for special pathogens. And over time, multiple units that used to be either orthopedic units or general care units have been converted completely into COVID units in order to handle the volume of patients that we've had. We've also had to convert entire intensive care units into COVID units. And I've highlighted in red, this is normally Bigelow 6 is a pediatric intensive care unit. They have specialized nurses and physicians who take care of children. And in fact, this has become an adult ICU in many respects. And then we have 3 units, and these units were never ICUs, and we've had to convert them, both technology, staffing, and workflows into ICUs in order to handle the volume that I described and showed you before. We've also had to then designate units as non-COVID units. We converted one of our units that was a post-acute care unit into an ICU. And then we turned a general pediatrics floor into an adult non-COVID unit. We've also had a lot of innovations with teamwork and designating special groups of providers to perform specific tasks. We have a proning team, we have a procedural team, and these teams are specialized in the care that they give, and they respond to various units in order to concentrate expertise in particular providers and to facilitate the workflow. We also establish outpatient respiratory infection clinics, and these clinics have been established where other clinics have been decanted. So normal hospital operations, you'll see, has changed dramatically over this time. And we started in that garage, and we've opened up many, many different clinics over this time that are specific for patients with respiratory illness and now COVID. We have very complex pathways for evaluating these patients to make sure it's done safely. And what's really been dramatic is this is counts of our kind of in-person visits in teal for last year at this time. And this is our current year. And you'll see that there's very few in-person visits in teal. And the majority of our visits have been converted into virtual visits. So this has been a big story about telehealth. We've also had to identify places to care for COVID patients who need regular care after they leave the hospital or after they've been diagnosed. And this is an increasing number of patients who need to be evaluated in our facility. We've also had to use employees in different ways than they've ever been used before. It's called redeployment. So individuals who their current clinics are closed because we've decanted a lot of the hospital, and now they're redeployed throughout all the hospital and all of our clinics. We've already deployed 700 nurses to new roles across the MGH. We've had nurses who are not ICU nurses who've been trained to become ICU nurses. We've had advanced practice professionals be deployed all over the facility and to our clinics. We've had to plan for surging over this entire time using predictive models of what we expect in terms of our ICU needs and our regular floor needs. And when we identify gaps, the red gaps in terms of staffing, we have to find nurses, physicians, other clinicians to fill those gaps. We've also been working, as this has evolved, in terms of equity and community health, recognizing the needs for multilingual registries and staff and trainees that are able to communicate to our different patient populations. This has been incredibly important, as you saw from the breakdown of our catchment areas, that there are certainly particular communities that have been adversely affected more than others. And you can see this by looking at the proportion of positives based on population. And here, Chelsea, Lawrence, Revere, and Lynn, these have all seen increasing number of cases, but also we've noted here that 35 to 40% of our COVID inpatients are Latino, the majority of whom are Spanish speaking, and this represents a multi-fold increase from our normal census. There are some community health hotspot strategies that are ongoing and have been launched in the last week or two. We are identifying hotspots by priority using incidence per 10,000 population. We've started in Chelsea and Revere. We're working on Hyde Park and Mattapan and looking to see where the next hotspots are. These are combined approaches of public health, mitigation, isolation, and communication. Testing has been a big part of this outbreak, and I'm sure you've read a lot about it in the newspaper. At the time when we activated, every single test that we wanted to do had to be approved through the Mass Department of Public Health. It required a phone call, waiting for a call back, describing the case, getting a decision, and then if approved, it went to the state lab and then to the CDC with a minimum 2 days turnaround, but practically our experience in the early days was over 5 days. And that cost us a lot, and there'll be lots of people trying to figure out how much it changed the trajectory of the outbreak, but certainly this has been one of our major struggles. We've definitely made a huge improvement. This is a figure showing our daily lab volume, which is now completely separate from the state lab. We are over on the inpatient side, looking at over 600 tests. We also are looking at the proportion that are positive. Just ignore this 100%. There was just a few patients tested that day and they were all positive. But over time, the proportion of positive has been going up. And that CDC definition of what how you were able to get a patient approved for testing is not relevant for us anymore, given our increasing capacity both here, externally at the Broad, and other locations. And now our current testing criteria has both asymptomatic screening as well as symptomatic screening, and it literally changes daily, where we have a multidisciplinary group meeting from across the partners enterprise, balancing, changing epidemiology, different use cases in terms of needs across the community, and making decisions about expanding our criteria pretty much every day. On days that we don't have enough capacity, either we don't have enough swabs or reagents or appointments, we have to pause and we then regroup the next day to see if there's any additional expansion in our testing criteria. You've also probably read in the news all the challenges with personal protective equipment and other supplies. This is never a way to put personal protective equipment on. I'm not sure why they included that picture, but certainly this has been one of the most anxiety provoking as well as challenging parts of this outbreak to be confronted with when normally our supplies are so plentiful that I think in retrospect, we don't give it a second thought that we have all these supplies, but that has been center on all of our minds. We've had supply challenges and we continue to do so. The N95 respirator, surgical masks, eye protections, even gowns at this point. The PAPRs, which are an alternative to the N95, disinfectant wipes have been running out. We are making our own hand sanitizer with the blessing of the FDA and other regulators, and then ventilators, certainly a challenge. With our N95s, we have implemented extended use or reuse. So these are typically typically in normal circumstances would be used only once. We also only had one brand that we had fit tested everyone to, and now we have multiple brands. We have a centralized distribution to limit excess use. And working with innovation groups had brought on several innovations. The innovation group was looking at reuse. They were looking at face shields, full body protection, surgical masks, ventilator options, and the N95 respirator group. We built a group, developed and brought to use, which is now in use, these personal protective booths that are used to obtain swabs from patients. They limit the amount of PPE we use, and they limit the potential for exposure. And then the Battelle Decontamination program that started a couple weeks ago and allows us to decontaminate N95 respirators and then return them to use. A lot of organization that goes into this and getting those respirators back to providers. Many policy changes, and I'll skip through these, but there were different kinds of policies changes. We had travel restrictions, we had meeting size restrictions, we then had screening restrictions for visitors and deferring of visits. We ended up developing a universal symptom screening prior to shift. So each day when I come to the hospital, I have to have filled out my attestation. This is a picture of my COVID pass. I am arrived into the institution and I get my surgical mask that allows me to enter the building. We have changed some of our infection control policies under the guidance of the CDC evolving guidance. And this is a look at what our personal protective equipment looks like right now in terms of a standard approach to these patients. We've had to, as I mentioned, extend and reuse devices that are single use in outside of these settings. We've also instituted the universal mask policy for employees at the end of March and then extended that to visitors and patients. We wrote a perspective piece on that in the New England Journal because it's not your standard approach to infection prevention. And we taught people how to use the masks. A lot of individuals who have not been used to wearing masks, but they come to our facility and they're required to do so. We've had really restrictive visitor policies. This has made a lot of news. It's based on the concept of reducing the potential for exposure. This has also led to some very challenging situations in which patients who are quite ill, who would normally have their family or others with them, are really restricted in the visitors that can be here. Lots in the pharmacy realm, as well as other things. So we basically shut down all elective procedures in March. We started mostly remote work. We've had restricted entry into the facility and lots of employee reassignment. I'll close out just with a couple comments on research, which is really, I can say it's going gangbusters here. Doing research in the middle of an outbreak would be just challenging under any scenario, but I'm just so impressed at the work that's been going. This is just a sampling of the 3 therapeutic trials that are ongoing with remdesivir. This is a multi-center randomized controlled trial. We've got an IL-6 receptor antagonist trial as well, and inhaled nitric oxide. There are many other studies that are ongoing and planned, epidemiological studies, seroprevalence studies, diagnostics, lots of health services research and outcomes, and obviously transmission dynamics. And the literature is going to be plentiful. It already is plentiful, but we are going to learn so much out of all of this. So that was a quick whirlwind tour of what's been going on here. It has been transformative on so many levels. The shifts are daily, sometimes from morning till evening. There have been changes in our approaches. We are, someone used the term once during the Ebola outbreak that we're building the plane while flying it. It sometimes feels like that, but it's built on a basis of a lot of amazing work over many years, developing the kind of approaches and the skill sets and the teamwork that makes this possible. We're going to learn a lot that we can apply when things get back to normal, and they're going to make our normal everyday clinical care better. I'm absolutely sure of that, and I'm looking forward to that. I'm going to close with a couple pictures. This is the Bullfinch building from MGH. This is the first building here. I'm actually sitting in it right now. This used to be the hospital. Lots of amazing things here. And for some reason, my last picture didn't show, and it was a really good picture, and I wish I'd been able to show it to you. Give me one second. it didn't show it. In any case, I'll stop here and I'll just give my thank yous. There's so many, I literally can't put them on the slide. I want to thank the MGH generally and all the people in it, and those of you who are not in the MGH who are supporting us in so many ways. Within the Hospital Incident Command and the Center for Disaster Medicine, many of the slides that I showed you showing our inpatient volume and ambulatory volume are from the Health Systems Engineering Group. They've been doing a lot of modeling, trying to figure out when we're going to peak here. And really so many here at the facility and the hospital who are working, I would say, round the clock. Nobody's sleeping very much, but we're all getting through it together. And I'll stop there. Thank you.
Thank you so much, Dr. Shenoy. That was really amazing, and I really appreciate you taking the time out of your very busy schedule. Do you have time for one question?
Sure, let's go it.
You have time for 2 questions?
Yes, 2. Let's do it.
It is. All right. Thank you very much. So the first question that we had posted here is: are there any indications yet of the extent of nosocomial COVID transmission?
Yeah, so the question is, have we seen nosocomial transmission? So we are not aware of this. So what we do right now is we track all infections. We also identify if there have been any exposures. Our exposures are fairly limited at this point. We are testing so broadly, and we're also masking all providers throughout the course of care, and our patients are actually masked when they enter the building. So that limits the amount of exposures. So I think that in general, we are in pretty good shape. Now, location of acquisition of infection is really hard, especially in a situation where we have such community spread, and because we know that even when infected, many individuals do not show outward signs of infection. And that, I think, has been very challenging from a public health and from a clinical perspective. And it's similar in some ways if you think about flu, where even the day prior to the manifestations of symptoms, individuals are infectious. And so for many reasons, this has been challenging. I think one of the main challenges has been the mild or pre-symptomatic infection that individuals have. We're constantly monitoring and on alert, looking to detect any possibility of nosocomial transmission. So that's a terrific question. There's one more, looks like.
Thanks. That was a terrific answer. The other question's a bit broader, in that recent reports have raised the possibility that SARS-CoV-2 might be aerosol transmitted, contrary to what had been believed up until now. What new challenges would this bring at a hospital level?
Yeah, so there's a couple ways to think about that. We still think that SARS-CoV-2, like SARS-CoV-1 and Middle East Respiratory Syndrome, is primarily large droplets that come out of your mouth, or when you cough, or when you sneeze, or when you speak. Now, just like those viruses, there are certain activities that can take those large droplets and turn them into droplet nuclei, which raises the potential of an airborne route of transmission. Because of this, from the very beginning, and this has been part of the CDC's guidance, is that when you're doing procedures or activities that could take those droplets and turn them into droplet nuclei, that you have to have the appropriate respiratory protection in case it is airborne. But I don't think anybody at this point thinks that it's airborne in the way that we consider measles or tuberculosis or varicella to be primarily spread by the airborne route. We are going to continue to learn a lot about this. I think the weight of the evidence at this time is that it's primarily droplets and then fomites when those droplets fall on surfaces, and then you touch those surfaces and touch your face, your eyes, nose, or mouth, you can transmit it that way. And then in specific circumstances, the opportunity to create particles that can be transmitted via the airborne route.
Yeah, and that thanks again, Dr. Shenoy. And I personally am compelled to say, in the